So welcome everyone to a webinar sponsored by Capricor Therapeutics. I'm Pat Furlong, and I'm really happy you're joining us today to hear about this very interesting and hopeful trial that is hoped to halt or stop the progression of dilated cardiomyopathy in Duchenne. I think all of you know out there as parents and key opinion leaders, when we see this diagnosis of Duchenne, that not only skeletal muscle is affected, but certainly smooth muscle and cardiac muscle. And so it's really a worry for every parent who has a young man and every young man who has Duchenne, the diagnosis, to think about what should we do with the heart, how do we protect it, how do we delay or halt the dilated cardiomyopathy that occurs. Today on the phone we have members of the company as well, of Capricor Therapeutics. We also have Caduceus on the phone from Coalition Duchenne. A little bit about so the process and agenda is going to be that I'm starting off. I'm going to talk a little bit about my relationship and our relationship with Cath and the Brandon family, actually, and then turn it over to Cath, who will begin to introduce this. This will then be interjected with questions along the way. We'll take your questions at the end. We'll wrap up talking about the procedure and also clarification of any questions we have or expansion of any questions. So I'm happy to have, as I mentioned, Caduceus on the phone. I've known them since Dusty Brandon was diagnosed, it seems a long, long time ago. Dusty's now in his 20s. We met them, and Neil Brandon, Cath's husband, was chairman of PPMD for many, many years, and together we started projects of the Dusty Brandon Fellowship, the DMDRC out at UCLA. Some of the antisense work was started here, certainly, and some of the tox packages on PTC Therapeutics. So today, Cath has been the incentive of this basic science work to really investigate this possibility in Duchenne. So I'm now going to turn it over to Cath, and then she will introduce Capricor Therapeutics. Cath?
Thank you, Pat. Hello, everyone. So I'm Caduceus, and I'm the founder and executive director of Coalition Duchenne. My son, Dusty Brandon, is 23. Coalition Duchenne, is very focused on funding cardiac and pulmonary initiatives. As you all know, cardiomyopathy is one of the main reasons we lose our sons so young. So that's why we're very focused on helping to change that. And Dr. Eduardo Marban has been a great ally. We first heard about Dr. Marban in an article in The Economist magazine of all places called Mending Broken Hearts, and that was back in 2011, which discussed using cardiac stem cells to treat the scarring caused by heart attacks in adults. So we immediately wondered whether his cardiac stem cell technology would be applicable to the scarring we see in all Duchenne hearts. So in 2012, actually, I was at a PPMD conference in San Diego. We met up with Dr. Ron Victor, and he helped make a connection with Dr. Marban. But as everyone knows, Dr. Marban is a very busy person, and I chased him relentlessly with emails and phone calls. And eventually he agreed to a meeting, and he had thought about disease-specific uses for cardiac stem cells, or CDCs, but we were gratified that he agreed to take on our $150,000 research grant and focus on Duchenne, and that was back in 2013-2014. Our study looked at the mouse model, and the results exceeded our expectations, and we are really excited that Dr. Linda Marban and her team at Capricor Therapeutics have now licensed the technology and have initiated the HOPE trial. Just one last thing, we have additional links related to Dr. Marban and his research, including an in-depth video interview with him and an NBC story that featured our initial funding on our website. So I'd now like to hand you over to Dr. Linda Marban.
So thank you very much, Cath. As always, your articulate description of the work is beautiful, and I could not do it better myself. I might take you on the road with me from now on when I talk about this trial. So let me talk to you a little bit about Capricor, a little bit about ourselves, and give you a snippet of information that can be followed up in detail on our website, which is www.capricor.com. Capricor is like the astrological sign without the N. Brian, can we move the slides now? There we go. So we're a publicly traded company, and so I might make forward-looking statements to which you can check the validity of our registration statements with the SEC. Next slide. So I think we've already had the introduction as to who's speaking today. I'll be first, followed by many other people that will help you understand the HOPE trial and its possibility for boys and young men with Duchenne muscular dystrophy. Please, next slide. Brian. So let me tell you a little bit about our cells. So our cells are made from hearts to be delivered back into hearts to make them better. We've been working with these cells now really for about 13 years. We've done hundreds of animal studies, and the cells have been in about 120 or 130 adults at this time in various flavors. I hedge on those numbers only because the current trial, All-Star, is randomized, placebo-controlled, so we don't know who's gotten cells and who hasn't, so it's an extrapolation of the numbers there. What we know about our cells are largely that their mechanism of action is through a paracrine effect. Paracrine means that they go in and they function as a local drug delivery system by releasing all kinds of factors. These could be proteins, cytokines. Cytokines are chemicals made by your body when an infection is present. And also microRNAs, which are communication devices between cells, to tell cells to change their behavior. So they can actually reprogram the ability of a heart cell. Our cells are made from the heart, and we know from spending the years that we have studying them that they speak the language of the heart. So when we put them down a blood vessel, a coronary artery, and you'll hear about the infusion procedure later from Dr. Jeffries, you'll understand that when the cells go into the heart, they go and they talk to the cardiomyocytes in a way that they understand and can change their behavior, prevent them from dying, which is called apoptosis, stimulate them to regenerate themselves to make new ones by re-entering what we call the cell cycle, which is how cells recreate themselves, and also calling stem cells in your body to the scene to fix whatever is broken. Our cells are made from donor hearts. These are hearts that could be used for transplantation but aren't used usually for technical reasons. So an example of that, for instance, would be if somebody had some type of a traumatic injury to the heart, so that they had a bruise or a contusion. No physician wants to put a person at risk by putting a bruised heart in their body. So that heart would come to us, and we take it back to our lab. And in the top of the slide that you see here, we show you the process that we go through to make our cells. So we start with a small piece of heart tissue, and we cut it up even further into something called explants. Then the explants are taken and put into what we call suspension culture, which means they're basically put into a fluid or a media. And then in that fluid, they become cardiospheres. Cardiospheres are 3D microstructures. They actually sometimes we call little hearts in a dish. They have all of the cell types necessary to become cardiomyocytes. But they're too big to put down a blood vessel. So then what we do is we take them and we put them into single-cell monolayer. The way that I think of that is when I think of a melting snowball. So you can think of a cardiosphere as a snowball, and then if you put it in someplace warm, like a flat surface, the snowball will melt down and become essentially a layer of water. That's how you can think of the cells. They become a single cell, single monolayer that can then be collected up into a dose of 25 million cells per dose and injected into the blood vessels of the heart, and that's basically the same way that you would do an intravenous delivery. It's just getting the cells exactly where they need to be. Okay, Brian, next slide. So the first clinical trial that we ever did using our cells was called CAduceus. CAduceus and some of the data that Kath actually originally read was from the CAduceus trial. CAduceus was done in patients, in adults that had a big heart attack. So a lot of their heart was damaged. And when a heart attack happens, what happens is that the blood vessel in the heart is blocked. Blood can't get through the tissue. Heart tissue, beats 72 times a minute. So it uses a lot of energy. So it very, very quickly starts to die when it's blocked, which is why it's very important to get to a hospital quickly if you think or you are having a heart attack. When the tissue dies, it becomes scarring. It becomes a scar like you'd have anywhere else on your body. I do a lot of cooking, so I have scars on my hands, and that's sometimes how I think of a scar in the heart. It doesn't look the same as the rest of my skin, and it doesn't function the same. Well, scar in the heart doesn't beat. like the rest of your heart does. And so what happens is it puts extra load on your heart. The heart dilates, it gets bigger to account for the scar, and therefore you end up changing the physical properties of how the heart beats and meets the needs of the body by contracting the blood. And so ultimately that's what leads to heart failure. So in CAduceus, we took people that were very high risk for heart failure, these people that had large scars from a heart attack, and we infused the cells down their coronary artery. And what we saw is that 6 months and continuing out to 1 year later, we had a significant reduction in the amount of scar in their heart. And that was also reflected in the increase in viable muscle. Viable muscle is contracting, beating healthy tissue. So we used an MRI. We used the exact same process that we're going to use in HOPE, which is we infused the cells, and then we brought the patients back 6 months later, and then 6 months after that, so 1 year after they got their cells, and we put them in the MRI machine, and they got the image. And what we found is that their scar size had been reduced by almost half in patients that were treated. So we were really excited about this data. You know, reduction in scar was the first time anybody had ever shown this, what we call evidence of therapeutic regeneration, the idea that tissue can be made in the heart after it's been dead. When I went to graduate school, we learned that the heart was a terminally differentiated organ, which means that once a cell died, that was the end of it. So this was extremely exciting, and we decided we wanted to move forward with our clinical trial work. But we also decided, so CAduceus was done using cardiac biopsy. So if you were a patient in CAduceus, we would bring you into the cath lab before you got your cells, and we'd have to do a little procedure in your heart where we took a piece of tissue called a biopsy, and then we'd make your cells from that. Well, what we realized is that was too much to ask patients to go through, and it also didn't guarantee that we were going to get the same cells every time. So we switched. We switched from using that biopsy-driven manufacturing protocol to the donor heart protocol that I told you about a few minutes ago, where now patients just get the dose of cells. They don't have to go through a procedure beforehand. And the upside of that for patients is we can completely and totally characterize and quality control our cells and measure their potency every single time. So we know that the dose that everybody is getting is going to deliver approximately the same effect. That discovery led to All-Star Phase 1, which is a clinical trial where we just looked at the same patients in CAduceus, people that had big heart attacks, and we validated that those off-the-shelf cells worked the same way. And the data suggested it did. So the Food and Drug Administration and our DSMB gave us permission to move to All-Star Phase 2, which is underway now. All-Star Phase 2 is exciting for us, and we should finish it this year, 2016, with data early part of next year in 2017, because All-Star is the trial that Johnson & Johnson, the large pharmaceutical company, has taken exclusive license option to ourselves. So if All-Star data turns out the way we think it will, with reducing the amount of scar as it did in the CAduceus trial and in All-Star Phase 1, then J&J has a good likelihood of bringing these cells in for future clinical development for adult heart disease. Not for DMD. Capricor is going to maintain the manufacturing, the distribution, and the commercialization of those cells ourselves. So the other clinical trial that we've done that was very important in queuing up the HOPE-Duchenne trial is called Dynamic. So Dynamic uses the same cells, the ones I've been talking about for the last little bit, in patients that have advanced heart failure. Now, these are adults that are very sick. They have what they call Class 3 heart failure. That means that, they get tired even doing simple activities of daily living. They're at high risk of mortality. There's about a 30% annual mortality rate for these people. And as a result, because their heart's not meeting the needs of their body very well, they have other problems that are called comorbidity. So these people are very sick, and we wanted to make sure that we could safely deliver our cells to these patients. And we also wanted to get a better coverage area of the cells. So in All-Star and CAduceus, we're delivering the cells down one coronary artery. In HOPE-Duchenne and in Dynamic, we're using all three coronary arteries to bathe the heart and cells and make sure there's good coverage. So we had to make sure that was safe. We did a dose escalation study in Dynamic where we, slowly treated up the number of cells that we were delivering. And I'm happy to say that not only were those cells safe, not only did the procedure go extremely well, but even more importantly than that, we saw hints of efficacy. So we saw that the patients did better. They felt better. They could walk farther on the 6-minute walk test. And then the measures of cardiac function, like ejection fraction and volumes are how the shape of the heart is affecting its ability to meet the needs of the body, were all improved. We reported that data at the American Heart Association. It's on our website, and I'm happy to show it to you if you have any interest in seeing it. So all of this was data that we used to support the trial with Duchenne muscular dystrophy. As Kath mentioned to you a few minutes ago, we've done a lot of work using the MDX mouse. While the MDX mouse is not necessarily the gold standard model in terms of cardiac function when the mice are young, once they're older, about a year old, they start to develop the cardiomyopathy. So similar to boys and young men with Duchenne, when they're very, very young, they may not have evidence of the cardiomyopathy. But as they age, as the disease continues, so does the cardiomyopathy. So we did those studies that were funded through Eduardo's lab by Coalition Duchenne. And let me talk to you a little bit about that data. So, Brian, can you move to the next slide? So first, before I tell you about what we found in the mice, let me tell you a little bit about what happens to the heart in boys with Duchenne muscular dystrophy. And the graph that is shown here actually is work that was done with John Jeffries, who I'm proud to say will be talking to you today, and is also the national principal investigator of this study. So I'm really excited to work with such a thought leader in understanding the cardiomyopathy. What you see here on this graph, which is published in the medical literature, is on the x-axis is delayed enhancement grade. That's imaging language for scar. And so with each level of enhancement, delayed enhancement grade, you're getting more and more scar. On the y-axis is left ventricular ejection fraction, which, as I said before, is the ability of the heart to meet the needs of the body. And what you see here, and this is actually a little bit different than what you see in adults and is very interesting, adults with heart disease, not adults with Duchenne, obviously, is that you see that ejection fraction remains stable. Cardiac function remains pretty normal as scar aggregates to a certain point. And then the heart can no longer compensate for the amount of scar that's in the heart. It can't beat very well against it. And so it falls off sort of a colloquial cliff where function declines. Decompensated heart failure occurs, and then the boys and young men either die from this or, of course, are severely impacted by impaired cardiac function. What we're going to try to do, and what we've demonstrated in the mice, is drive the heart back up that hill or keep them at the top of that hill so they don't fall off the cliff. And we can do that by the mechanisms that we believe our cells are so adept at doing, which is reducing scar. So if new tissue is made, then the cells are actually healthy, the muscle's healthy, it beats better for a while. Sure, over time, the cells may be affected, the muscles may die. Once a year, once every 2 years, people might have to come back in for another injection of cells. But the important thing is it's going to keep the heart working well, and that's what we believe will happen in response to treatment with our cells. So Brian, can you move to the next slide, please? So today is about the clinical trial, and we want to tell you all about how the procedure is going to be done, what the structure of the trial looks like, how you can get into it, and those kinds of things. So I didn't want to spend a lot of time talking about the preclinical data, those MDX mouse data. They are, as I said, on our website. Cass knows them, Pat knows them, and I'm happy at any point to chat with you, either online or offline, regarding that data. But what we show here in these bullet points is exactly what we found in the mouse heart. And I want to tell you about them and highlight two things very quickly. One, it improved cardiac function, so ejection fraction improved significantly in the mouse heart. And if we injected cells again after the effect began to wear off, we could get the effect again, so it happened again and again. The scar in the heart decreased. We actually could see less scar in those MDX mouse hearts. And what's perhaps even more important and one of the best findings in the study was that exercise capacity in the mice were increased. So they were able to run on a treadmill. We put them on the treadmill week after week, and the mice that got the cells could run farther and longer than those that did not. So this is very exciting data because this then supports the fact that with their hearts getting better, they're actually feeling better. Now, we also have some more lab work going on in the lab to suggest that there might be off-target skeletal muscle effects. And stay tuned for some more data on that as it comes out over the next year or two. But what we know is, at least in early stage data, that if we inject these cells into the heart, there also seems to be a benefit in terms of skeletal muscle. The way this effect is mediated is through the mitochondria, and the mitochondria is the furnace of the cell. It's just like furnace in your house. You turn it on when it's cold, and it warms it up. The mitochondria makes the energy that keeps the cell moving and functioning and able to do its work that it does. In DMD, what happens is the mitochondria die for reasons of the dystrophin mutation, allowing the membrane to be permeated by calcium, and then it can't generate energy, which ultimately leads to the cell not functioning well and then dying. We've shown that the mechanism of action of our cells is by restoring mitochondrial structure, function, and number. So with that in mind, I have given you sort of an overview of Capricor, an overview of our technology. Like I said, Johnson & Johnson has taken an exclusive license option on these cells. They spent over a year doing due diligence to make sure that all the data that we have said is actually supported by good science and strong medicine. And so we believe that we have a good opportunity to really make a difference in this very serious complication of Duchenne, which is the cardiomyopathy. With that, I will turn it over to Dr. John Jeffries.
Yeah. So, Linda, it's Pat again. So just before we switch to Dr. Jeffries, I just have a few questions that I'd like clarification on. One is in the first study, you talked about the fact that you biopsied individuals, human beings, hearts, and used cells. And when you use cells that are a person cells, that's autologous, right? That means self. And then you switch to allogenic cells, which means that you're taking them from a donor heart. So I wondered if you have to, or if you thought about, or if you do use immune suppression protocols in your studies, and how you think, or if that's necessary in Duchenne, recognizing the fact that the boys are already on steroids. So that's my first question. Are you anticipating any rejection? Are you worried about it? Will you control for it, or is that not a problem? My second question is related to the mouse. You said that you treated the mouse and things improved, which is terrific news, and then you had to retreat. And so as we think about the HOPE trial, and I know the HOPE trial involves a single injection through all the coronary vessels to the heart, but do you suppose, or are you thinking about reapplication of the therapy as a necessity, and have you conceptualized what the time frame might be should that have to be done?
Yes, thank you, Pat. Two very excellent and appropriate questions, so I really appreciate it. So in terms of the first question, when we went from autologous to allogeneic, we had to do a lot of preclinical work. We used immunology consultants. We worked with David Sachs at Harvard, who actually had run the immunology division of the National Institutes of Health for many years before going to Harvard. He's probably one of the biggest experts in the world on transplantation biology, and we first had to demonstrate in animals that our cells were not going to cause an immune complication in terms of safety. Then we went up the ladder and we brought in all kinds of key opinion leaders, including most notably Dr. Paul Terasaki, who actually was one of the people that invented tissue type matching for organ transplantation. He's a transplant immunologist who is beyond of world accord. And Dr. Terasaki did a lot of experiments with us and analyzed the data, and what we found is that this number of cells that we inject in patients is so small that it doesn't cause any kind of immune response. And we've now done this in many, many patients, at least 28 we know from 14 in Dynamic and 14 in All-Star Phase 1, and then a number in All-Star Phase 2 that I'm not sure of because of the placebo-controlled nature of that trial, but enough patients to know that we have seen absolutely not one safety signal in terms of an immune complication in non-immunosuppressed individuals. So these are completely, normal, non-steroid-taking adult people. And so what we did find, however, is that if we tissue type match, which is pretty similar to what happens with organ transplantation, if we make sure that the recipient, the patient, doesn't have antibodies to the donor cells that we're using, and we have multiple cell banks, so we're very careful to make sure, using software, that that's done correctly, that matching, it impacts the efficacy, the ability of the cells to mediate their biologic effect. So it wouldn't be a safety issue, and in fact, in All-Star, we actually have a small group that we call the exploratory cohort, patients that don't match to any of our tissue banks, but actually are getting cells anyway. And we haven't had a peep of trouble in terms of immunology there. But Dr. Terasaki felt that the efficacy of the cells might be compromised because the body of the patient would kill them quickly if they recognized them as foreign. So the answer to that is no, we're not immunosuppressing. No, we don't feel we need to immunosuppress. And no, there's not a safety issue. And yes, we tissue type match because we want to try and enhance efficacy the best that we can. We're actually really excited to put the cells into the DMD patients who are on steroids because we don't know in that type of a scenario how it would impact any of the activity of the cells. We don't believe that there will be any because of this low immune complication risk anyway. But this is why we do these clinical trials and do a small number of patients to start with, so that we can see what the biologic effects are. In terms of your second question, with repeat dosing, we don't know what's going to happen in people. We don't know how long the effect's going to last. We wanted to do two things in the animal study. One, we wanted to validate that we could repeat dose and get a sequential biologic effect in case we had to do that in people. We wanted to have that information at hand. We wanted to understand the immunology there because of repeat dosing. Could we potentially not have as good of a response? And we found that wasn't an issue either. In terms of whether we will do that in patients, of course, if the effect begins to drop off, we want to have that ability to do that in the Duchenne patients. We're anticipating that if that occurs, it would be every 1 to 2 years. Certainly, we don't anticipate more frequently than that. But again, that's one of the purposes of this initial study. It's why we're tracking the patients so carefully, is so that we can understand when or if the results wear off. And then I think the plan would then be to be able to make sure that these people could get back in for a redosing should they need it.
Great, thanks. And a last question, there is also one coming in about how you do some tissue typing. Are you doing HLA-1 and 2 typing to understand the match and to see if these patients have high antibody levels? And then what happens if you find that? So you're doing that. Okay, last question before we turn to John Jeffries is, have you considered, as you in your presentation mentioned that the MDX heart is not as certainly as involved as the young man with Duchenne's heart, have you considered a parallel study with dogs as you begin this trial so that you could maybe better estimate what exactly happens as the dog's heart, the dog model's heart is severely affected, and or maybe have some insight into whether or not you'd have to repeat the procedure?
Yes, that's a really good question. I'm glad you asked it as well. So I have a PhD in cardiac physiology, and all of my work over many, many years before I went into biotech was on animal models of heart failure. And while I didn't work on Duchenne muscular dystrophy because nobody really was paying attention to the cardiomyopathy then, I worked on a lot of different types of heart failure, and I actually worked on the immune complications of heart failure for my thesis work. And one of the things I had to do was study a lot of different animal models. And one of the things that we realized is along the way is that the dog heart, and this is not me, this is the field, is not the same structure, physiology, or capacity as the human heart. So even though the golden retriever dog model has a severe version of cardiomyopathy, I don't think it's going to give us any more information that would supplement what we already have in the MDX mouse, the dynamic patients, the CAduceus patients, and the all-star patients, to support going into the boys with Duchenne to actually see if this mechanism that we've identified in humans and in pigs and in mice actually maintains itself and works in the boys and young men with Duchenne. I would be a lot more hesitant to proceed directly into humans if we didn't have such good human data. But ultimately, when cells die and fibrosis occurs, which is what happens in adult heart failure and Duchenne muscular dystrophy-associated heart failure, with a heart attack, with all these different mechanisms by which muscle dies, the fibrosis is basically the same process. The scar accumulation is the same process. And so we believe that all the data that we have supports doing the human trial, seeing if we can get the same result, which we're fully anticipating that we can, improve cardiac function, and move this towards commercialization where it can be available all over the world to boys and young men with Duchenne without having to go through yet another preclinical study, which potentially could raise more questions than it answers.
Sure. Thank you. And that's a great segue into Dr. Jeffries. Dr. Jeffries comes to us from the Cincinnati Children's Duchenne Muscular Dystrophy Center, and he will present the process, the procedure, and talk about the trial. Thanks, Dr. Jeffries.
Thanks, Pat, and thanks to everyone for listening in. And I want to echo the statements that you've heard from Linda, that we're hugely excited about this study, and we think that it really can revolutionize how we deliver cardiovascular care for patients with Duchenne. And so I want to talk briefly about the study, recognizing there are a lot of nuances that we don't have the time to go through, but I want to encourage everyone to feel free to reach out to me if you have any specific questions that I can answer. So as you heard from Linda, this is a very novel trial, one that, as a cardiologist who sees lots of patients with neuromuscular disorders, this is a very novel approach. The idea of using cardiac-targeted therapy, specifically stem cell therapy, is very exciting. This is going to be a phase 2 randomized open-label study, and I'll explain a little bit more about what we mean by that in just a couple of minutes. And we're targeting patients that have cardiomyopathy that is secondary to DMD. And the cardiomyopathy definition that we're using is a little bit different than what we would traditionally talk about in some of the papers we've written about DMD. You don't actually have to have the overt dilated cardiomyopathy phenotype, and I'll explain what I mean by that in just a few minutes. This is a one-time delivery, and the total infusion would be between 50 and 75 million cells. And as Linda had explained, we plan to target all 3 coronary arteries, so that would be the left anterior descending, the circumflex, and the right coronary artery. And that's in an effort to distribute these cells relatively homogeneously to all of the myocardium. We talk a lot when folks come to our clinic or any clinic that deals with Duchenne. From a cardiac perspective, we focus a lot on the left ventricle and the left ventricular size and systolic function. But increasingly, we recognize the right ventricle is also contributing to some of the heart failure that we see long term. Especially in patients that have concomitant pulmonary issues, the right ventricle is very subject to failure. And that right-sided function actually contributes to how the left side functions over time. So the delivery of this in a more broad way to the total of the ventricular myocardium is very advantageous, we think. So our primary objective is looking at safety, as everyone understands. This is an important thing, and for our center and all centers that are involved in Duchenne care, we're very protective of our young men and boys with Duchenne and want to make sure that we don't incur any harm, and so safety is very important to us. And after reviewing all of these data, I feel very comfortable that this will be a very safe procedure, and I'll explain a little bit more about that in just a second. Also, obviously, we want to assess for tolerability, making sure that when patients receive these cells that they're well tolerated physiologically, and we have very strict and thoughtful assessment parameters to make sure that things go as they should. We have other secondary objectives, and part of that is really based on, are we making favorable differences in the myocardium, really based on scar tissue, and that surrogate assessment that we use MRI for. We look for these things called late gadolinium enhancement, which is really sort of an indirect assessment if there is fibrosis in the heart. And we really want to leverage that aggressively based on what you're hearing from Dr. Marban to see if we can make a difference. But we're also very excited about the possibility of changing other functional parameters that may include skeletal muscle function. It may include pulmonary muscle function. So there are other potential benefits to this study that we hope to uncover, and we're going to collect those data to try and give us some insights into that. Next. So the study design is we're going to enroll 24 patients, and I'll tell you a little bit about how we arrived at this study design, and most of this was driven by discussions with the Food and Drug Administration. So typically many studies that we would look at in adult cardiovascular medicine would involve a placebo group, and they fortunately for us allowed us to not pursue a placebo group, which involves a lot of technicalities and potential for shams and these other things which we didn't really feel very comfortable with. This gives everyone an opportunity to know where they're going, what arm they're in, but more importantly, I think really gives us a chance to get to where we're trying to get to a little bit faster. We have 2 study groups, Group 1 and Group 2. And Group 1, once again, these are patients that are 18 and older, and that was dictated by the FDA. And they wanted us to show safety and tolerability in patients over the age of 18 before we went into a younger age population, which we're happy to do. So the first 6 enrolled into the study will be at least 18 or older, and then the subsequent group will be opened up to patients 12 years or older and over the weight of 50 kilograms. And 50 kilograms was just something based more on the ability to technically deliver the cells via left-sided heart catheterization. So, and it's a one-to-one randomization, and what this means is that you'll go through a screening process, randomized potentially either to an infusion or to your usual care. And we don't know that obviously on the front end, but this ultimately translates into 12 patients that will be receiving infusion and then 12 patients that would be receiving usual care. And the usual care can be whatever your local cardiologist is providing. So that may include things like ACE inhibition or beta blockade. In our instances, for patients with fibrosis, sometimes we use mineralocorticoid receptor antagonists such as spironolactone or eplerenone based on some data that we published prior. But the good thing about this study is that there are no inclusion or exclusion criteria that are really driven by your cardiovascular therapy. So if you're on no medications, that's okay. If you're on optimally directed medical therapies, that's okay too. And I think that opens up a lot of opportunities for our patients. And we do feel that, regardless of what your baseline therapy is for cardiac disease, that this therapy is potentially very additive. This is very novel, as you heard from Dr. Marban. The idea of delivering local and directed therapy that might have direct influence on fibrosis burden is a huge deal. And it's very simple. If you can mitigate the fibrosis burden in a heart of a patient with a dystrophinopathy, you, in theory, can maintain their systolic function in the normal range indefinitely. So she showed you a slide about the correlation between fibrosis burden and a decline in ejection fraction. If you can control or potentially reverse fibrosis burden, you can sustain systolic function or even potentially improve it over time. That's hugely important to us in the cardiovascular field. If we can maintain good function, we can avoid heart failure, we can mitigate the potential for arrhythmias. So it has tremendous implications long-term about cardiovascular health and outcome. Next. So who is eligible for the study? Our inclusion criteria is able to provide informed consent, and that would be, for our patients 18 and older, they could provide their own informed consent. For patients younger than 18, that typically involves their legal guardian providing informed consent, and then the subject themselves providing assent, meaning that they verbally agree to the study. They have a historical diagnosis of DMD, and we would be looking for evidence of dystrophin-mediated cardiomyopathy. And the enrollment criteria are quite broad, which is very good for us because it gives us an opportunity to really capture a very broad number of patients. You can have an ejection fraction that is 35% or higher. So that means even if you had a normal ejection fraction, you could potentially get into the study. What we're really looking at more is the involvement at the myocardial level as dictated by MRI, with 4 or more segments having evidence of scar tissue by that process of late gadolinium enhancement. So if you have 4 segments or more, regardless of your EF, as long as it's over 35, you could be a potential candidate for the study. We've tried to find patients who are on systemic glucocorticoids for at least 6 months or longer, and that's simply to give us more homogeneity on our cohort. And it does provide, as Pat alluded to from a question, is that there may be some benefits to that from an immunosuppression perspective. We don't really know that right now, but this was more so that we didn't want patients that some are on steroids and some are not. That could be a real confounder, as many of the folks on the call know, that the use of steroids has been implicated in different directions as potentially cardioprotective or potentially cardiotoxic. We don't really know unequivocally about that, but it sort of takes it out of the equation. And then these enrollment groups, as I talked about, Group 1 is 18 and older, total of 6 patients. And then Group 2 would be the remaining number of patients. It can be 12 or older and 50 kilograms or heavier that would be enrolled, and that would be a total of 18 patients. Next. Our exclusion criteria, these are things that I think would be, obvious to most folks, and this is simply because a lot of these things we wouldn't want to take someone to the catheterization lab potentially who is too sick to take, to undergo the procedure in a safe way. So this is really because we don't want to incur any harm. We were pretty thoughtful about the exclusion criteria. We wouldn't want someone on inotropes or intravenous vasoactive medications that would usually implicate that they have end-stage heart failure. We wouldn't obviously want to consider someone who could not undergo cardiac catheterization and or MRI simply because they wouldn't benefit from the therapy, and we couldn't do surveillance on the therapy over time. We would try and avoid patients who have major surgeries that are planned within the next 12 months. We recognize that not everything can be anticipated, but it's simply because, as you all know, the surgeries, especially orthopedic, any kind of spinal surgeries in our boys and young men, are a tremendous physiologic insult, and it really would confound some of the things we're trying to look at. We would avoid patients on LVAD therapy, obviously, because, once again, that implicates end-stage heart failure. We would avoid patients with a thing called an estimated glomerular filtration rate, so that's an idea of how the kidneys are functioning. If that were less than 60, we would not want to enroll those patients because the contrast agent that we use for the MRI, which is called gadolinium, can sometimes be toxic to patients that have depressed kidney function. We would avoid patients with previous stem cell therapy, and we would avoid patients with uncontrolled diabetes, which would be defined as an hemoglobin A1C greater than 9. Next. So I'll turn it back over to everyone, but I do want to reiterate that we feel that this study is exceptionally important. We think it's highly innovative, and most importantly, as a person who cares for a lot of boys and young men with Duchenne, is that I do feel it's a safe study and that one that really has a tremendous amount of upside. The potential for a coronary intervention is unusual in our Duchenne population. But remember, coronary interventions are done thousands of times across the United States every day, and we feel very comfortable that patients will tolerate the procedure and that it will go without difficulty, because the infusion of cells is a very different prospect than what we do oftentimes in adult cardiology, such as placing stents or doing balloon angioplasty. So I think the procedure will be very well tolerated and has a lot of tremendous upside, and once again, we're very excited about the possibility, and thank you for your time.
Yeah, thanks, John. That was very helpful, and I don't disagree with you that the procedure is done frequently across the United States and across the world. It's just that the procedure is new to the Duchenne world, and so it's something that we have to really carefully explain and understand as parents and family members so that we can ask the right questions and make the right decisions. So next, I believe, Deborah, you're going to talk about the procedure itself. Is that right?
Yes. Thank you, Pat.
Thank you.
And thanks, John. I'm Deborah Ashheim. I am the Chief Medical Officer for Capricor, and until 5 months ago, I, like John, much longer than John and longer than I'd like to admit, was a clinical cardiologist in New York focused on treating adult patients, I should say, with heart failure. So feel free to send questions my way as well. But I'm just going to briefly discuss, for the reasons that Pat said, the two bigger procedures that we need to consider, or that you need to consider when you're thinking about potentially participating in the trial. The MRI, which clearly there's much more experience with in the community and Duchenne patients at this point, and in particular the angiogram. So just to start briefly with the MRI, probably as many of you know, and many of you or your sons have been experiencing, although clearly not all, MRI is becoming increasingly a routine part of clinical care in patients with Duchenne cardiomyopathy and tracking in advance of the cardiomyopathy. So what we are focusing on, just from a trial perspective, before we speak for a second, just about the sort of practical perspectives of doing an MRI scan in someone who's suffering from Duchenne, is identifying patients with, as you heard earlier, at least 15% scar in the ventricle. And that's somewhere around, basically when an MRI scan is done, the computer literally virtually chops up the heart, takes segments of the heart, and can evaluate these specific segments. And we're looking for involvement of somewhere around upwards of 4 to at least to 17 segments involved. And the scans that will be being done will be done at baseline, first to document that there is the minimum scar affecting the heart at that point, so that the patient would then be potentially eligible for the trial at 6 months and at 12 months. All of the scans for the trial are then what's called de-identified, so your or your son's name would actually be removed from that scan, and there's a subject identifier, literally a code that's put on that scan, and it's transferred to Johns Hopkins University, where the core lab is to analyze them. The trick is we really don't want you don't want people who may even have an unconscious connection with the trial, enthusiasm or lack thereof, but particularly an enthusiasm for wanting this to work, to be the ones reading the scans. You want it to be as objective and as independent as possible, and that's why we're using the core lab. Now, in terms of the more pragmatic aspects of getting a scan, laying down in the scanner, et cetera, and these are issues also, obviously, that we'll return to when we just talk briefly about the angiogram. In fact, most of you are at centers where increasingly the scans are being done, and there are nuanced techniques that the MRI techs and the MRI departments are learning around how best to position particularly the older boys and young men who may already have contractures. But clearly, and actually John, at Cincinnati, Dr. Jeffrey's center, they do routine MRI and have a lot of experience in terms of positioning the boys so that it's, both comfortable enough and doable. So we can always return to that, and if John's still able to be on the line, he could probably answer some questions. But I think in terms of the ability to do it, there are going to, that is clearly going to be one of the considerations in terms of whether or not somebody's eligible. That's not to say that having any contractures makes somebody ineligible at all. It simply means that if the skeletal effects of the Duchenne is so advanced that really it is not possible, despite a lot of tricks of the trade at this point, then the patient wouldn't be eligible. Okay, next slide, please. Now, in terms of the angiogram, and as Pat said, I think it's absolutely appropriate that this should be a primary focus of discussion, because not only is this an intervention that has not routinely been done in boys and young men with Duchenne, but in fact, it's something that I have no doubt you've all heard many, many times should not be done, because as historically there hasn't been a reason to do it. This is not the cardiomyopathy associated with Duchenne is not something that's caused by damage to the coronary arteries or some other reason that we would routinely be doing an angiogram. So this obviously is the first time to even begin to consider it. As John mentioned, there are, in fact, for the broader population, the non-Duchenne population, actually over 1 million procedures done annually that have to do with putting catheters into the heart, and around 600,000 of those annually actually are even that much more similar to what we'll be doing to infuse the coronaries by putting a catheter into the coronary arteries, each one, the 3 coronary arteries. Generally, in order to perform an angiogram, use what's called conscious sedation, so a little sedative that's given intravenously, and local anesthetic. The local anesthetic is essentially what you get at the dentist. It's just a local injection under the skin, so that the pressure and the discomfort you don't feel. Now, there are 2 ways of routinely doing angiograms, and this is really relevant to the Duchenne population in specific. The historical most common way of doing an angiogram is lying somebody flat on the procedure table and putting a catheter in through the groin. And actually, in a minute, I'll show you the next slide, which it just got too busy on this slide to show you the image of the heart to give you an idea of where we're going with this catheter. But the patient would lie flat, and the area just at the side of the groin would get numbed up with the lidocaine, and that's where the catheter gets put in. It gets put in there because it's a large vessel which has a straight shot to the heart, and so it's sort of the most straightforward and least complicated, historically considered the least complicated way of going in. Now, obviously, because of issues around contractures and the effects of Duchenne on the body over time, laying flat may be challenging and sometimes impossible for this population. Conveniently, over the last 15 or so years, I mean, it's certainly been done for longer than that, but there's been increasing use of access for the catheter through the wrist artery. And that for this population may, in fact, it really varies from interventional cardiologist to interventional cardiologist and center to center, which technique they use. But there's a growing, very large body of evidence about the safety and actually the frequency at this point of using access through the wrist. So, we'll see. I think we'll probably over time have experience both ways in patients with Duchenne, simply because of both physician preference and the patient's body and what they're able to do in terms of lying down on the table. Now, once access has been achieved, you put a little floppy catheter into either that wrist vessel or the groin vessel, and then a smaller, floppier catheter gets just threaded up into the coronary artery, and then through that, and I'll go back to this again with the schematic, but just to finish talking you through the broader issues, and then a thin tube. It's almost like a straw. It says non-occlusive infusion, which basically means you put in this thin floppy tube. It has a hole in it. You infuse the cells through that hole into each of the three coronary arteries. So it says the procedure is going to be repeated in each three arteries. That it's not necessarily the procedure. It's that each of the three arteries will get infused. Now, as Dr. Marban was saying earlier, the maximum number of cells that can go into an artery is 25 million. And everybody's anatomy, regardless of whether or not they're an adult or a child, the coronary anatomy differs. There's expected sort of standard norms, but sometimes one of the coronary arteries is significantly smaller because the other two are larger and infusing more of the heart muscle. So what the interventional cardiologist will decide at that point, having looked at those arteries specifically during this procedure, is, okay, are we infusing two of them or three of them? And the whole point is to infuse as much of the heart as possible, so presumably it'll be three. But if one of those arteries is smaller, then it'll probably get half a dose, 12.5 million cells. And that's not to say that, that patient is getting a suboptimal dose. It's simply that you also don't want to give too much in an area if it's actually not going to get into a proportionate amount of muscle. Then the patient will stay in the hospital overnight. Now, routinely for angiograms, these days you go home the same day. If it's being done for a clinical reason, even for patients who are much sicker with much more advanced heart failure or heart disease. But that said, given the fact that this is an investigational intervention and we, are taking all precautions as we should, patients will be put on a routine EKG monitor during the procedure, and that will continue. They'll be continually checked overnight with EKGs. We'll be getting routine blood tests also, just to measure and make sure that there's no, even if there are no symptoms at all, we just want to make absolutely sure that there's no damage to the heart muscle that might have gone under the radar. We're not expecting any, but just to be on the safe side. Now, the other thing I should mention, because I know that it was, I believe it was asked by one of the people who have written in earlier, in terms of blood thinners, there is a short-acting blood thinner that's routinely used during an angiogram, because basically any time you put something into an artery or into a heart that's a foreign body, like a catheter, you increase the risk of having a blood clot. And number two, the cells that we're using, as Dr. Maban said earlier, they're bigger than a blood cell, and so you don't want them to clump up and to cause literally just a mechanical blockage in the artery. And so there's a little bit of blood thinner that's used in the preparation of the cells themselves. Next slide, please. Okay, so this just gives you a much clearer picture of what I was talking about. The femoral axis, that's the groin axis that you can see where in this cartoon where that tube is going into the person's groin. Radial axis happens from the wrist to one of those arteries. And you can see from either of these ways in that it's a pretty straight shot up to the heart. And then if you look at the heart schematic, that green tube gives you a sense of where that catheter is coming from. It's a little bit of you have to use your imagination a little bit. And when we say it gets injected into the coronary, you can see that green tube is literally placed into that one large coronary artery, which is the left anterior descending that's going into the heart, and that's where those cells would be infused. Next slide. Okay, I spoke for a long time. I'm going to turn it over to Brian for kickoff.
So, Deborah, let me just interrupt you for 1 minute before we wrap up with Brian and ask you a few questions. First of all, I think this community appreciates the use of a core lab, because having the cardiac MRIs evaluated at a single institution, Johns Hopkins, will really decrease the chances of variability in terms of readouts. So that's terrific. I wondered in the post-op, once the angiogram is complete and the individual has spent the night at the institution and then goes home, will he be wearing a Holter monitor for a period of time so that you can take a look at that heart rate and the heartbeat so you can see what's going on? And so I'll ask you to answer that. And also, in terms of the procedure itself, can you give the community some guesstimate or estimate? And I recognize this has to do with what artery and what other complications in terms of getting up to the coronary arteries. But in general, how long does the procedure itself take?
Sure. Let me start. I'll work backwards. So the procedure itself, and I should have mentioned this, takes, with all the startup, et cetera, probably around an hour. But obviously not that whole time is not doing the procedure. But yes, the patients will be wearing a Holter monitor, a 24-hour Holter monitor, while they're in the hospital, and we'll be analyzing that as well. Obviously, we do want to look for, we'll see any irregular heart rhythms in the lab, because obviously the patient, I shouldn't say obviously, but the patient is hooked up to a monitor while the procedure's ongoing. And then we'll be getting the 24-hour Holter while they're in the hospital. We'll also be getting some subsequent ones, which you'll hear about from Brian. But I should also mention that, because I know that this is an appropriate concern, In general, the risk of a ventricular arrhythmia, which obviously is the most concerning type of arrhythmia in patients who undergo an angiogram, is around 1 in 1,000. Now, clearly, patients who are healthy don't undergo angiograms, but everybody goes in for different types of cardiac reasons. So, and if you're that one of the 1 in 1,000, it doesn't matter that there are 999 others that didn't have a ventricular arrhythmia. But it is a low incidence, but it is real. The risk of any type of an abnormal heart rhythm, so an atrial arrhythmia, et cetera, those that are perhaps less, or I shouldn't say perhaps, but are less concerning, is about 1 in 100. And again, the thing that the Duchenne patients, the one thing, in fact, that the Duchenne patients in this regard really do have going for them is that they're young. And so their hearts really are, although affected by the scar, and the scar itself, obviously, the concern is that, like a older heart with a heart attack can be a source of arrhythmias. We don't expect that the incidence will be higher than it is for the general population who undergoes these types of tests, the angiograms, because it's a sick population. But obviously we don't know, and therefore the most important thing is for us to be doing sort of the additional monitoring and taking the precautions.
Right. Thank you. So in terms of the procedure itself, going through the groin or the wrist, this will be up to the patient, the doctor, and the patient, and the access that they have. You aren't going to try. We have one question about going through the neck, and I'm assuming that you don't do that. I haven't seen that done as a routine procedure, and I wouldn't guess it would be done here. So a lot of how you go in will be determined by the patient, the contractures, the availability of the vessel, and the strength of the vessel. One other question that I have is, in general, what we see in boys with Duchenne is it's really hard to draw venous blood from them. As you well know, dystrophin is absent in all tissues, so that makes those vessels, all of them, a little more difficult to access. Sometimes they go into spasm. So I wonder if you're sort of planning for that, or if you've had any experience with that in this space.
Yeah. No, thanks. That's another great question. So those tend to be the smaller vessels that we draw blood from, as opposed to the vessels from the cartoon. You can see, if we go back one slide, the vessels used for the angiogram are many orders of magnitude, in terms of getting the access, many orders of magnitude larger than the ones that are routinely used for blood draws. Now, and it's arterial access as opposed to venous access. That said, we're just going to, in terms of whether or not the coronary artery, which again is larger than an artery that you draw blood from, but significantly smaller than say the femoral artery, whether or not we see any spasm there, we're simply going to have to wait and see. Now, in order to, that can happen. It's called coronary vasospasm. That can happen for really anybody, so that the interventional cardiologists will be, on the lookout for it. And one of the techniques that is used is putting a little bit of nitroglycerin, which is a very short-acting vasodilator, into either the cell preparation itself, or the wash. After the cells go in, there's a little bit of a wash that gets injected into that tube, just to make sure that all the cells are actually deployed and out of the tube and into the artery. Right. And so if there's any spasm at all, they'll just use the nitroglycerin. There are some, we really do leave that in the hands of the interventionalist who's at the bedside making the decision, as opposed to mandating one way or the other, because we feel that that really should be a clinically driven decision, but we make sure that the process for using it is standardized if they choose to use it.
Thank you. As parents and young men, I don't disagree that the arteries are hugely bigger than the veins that we're drawing venous blood from. But I think we're all sort of in tune with some of the spasms that can occur in these vessels, and I think we want to make sure everyone is quite aware, especially in those coronary vessels, to be attentive to that. And I agree with you, nitroglycerin would be the drug of choice to get that vasodilation to happen. One last question, and then we'll turn it over and wrap up. And that's really about the blood thinners. What's the half-life? What do you have to do in terms of precaution following the procedure to make sure that there's no bleed? And how long how long is the duration when you know that blood thinner is out of the system?
Right. So the blood thinner is heparin, and when you're giving it in higher doses to really fully what's called anticoagulate, thin the blood systemically throughout the body, the half-life is about a half an hour. We're giving it in much smaller doses, but I think that everybody sort of considers, okay, that's a reasonable guesstimate for the half-life regardless. But we're giving it in much smaller doses. And basically, what's done after the angiogram is in my day, way back when, we would literally manually hold pressure on the groin to make sure that artery had, half hour, 40 minutes to really heal up, and it does. But these days, there's actually a little bit of a sealant that's used to, and this is done routinely in all angiograms. This is the way it's clinically done. It has nothing to do with this study. But the sealant is used to seal things up and help it sort of heal even that much more rapidly, almost instantaneously. That said, always keep a close eye on either the groin or the wrist, the access site, over the course of the next several hours. And that's the routine procedure where somebody would go home that same day. For these boys and young men, obviously it's going to be followed throughout that 24-hour hospitalization.
Yes, thanks, Deborah. So I too have been in where we've anticoagulated patients, and I've been with my fist in somebody's groin for about 45 minutes as well.
Yep.
So I am very familiar with the sealant and agree that that's very effective, but precautions need to be taken. All right, thank you, Deborah. I appreciate the answers to the questions. With that, we're going to turn it over to Brian.
Very good, thank you. So we'll quickly wrap up this webinar with a brief overview of some of the additional study assessments you'll see in the HOPE trial, as well as some considerations for the families in their travel, and then finally where you can actually find a study doctor that's participating in the trial. So very quickly, for the study assessments that either you or your son should expect to be completing if they were to participate and enroll into HOPE, would include standard of care procedures, and standard of care procedures include such as vital signs, 12-lead ECGs, the noted 24-hour EKG recordings we were just discussing, as well as physical exams, review of medical history and concomitant medications, as well as routine clinical laboratory safety tests to make sure everything is going well hematologically and in your chemistries. Additionally, safety is paramount for the trial, so we will really do what we can to make sure all aspects of safety are monitored. So this also includes monitoring of your immunogenicity response to the dosing of CAP-1002 if you were to receive it. So we will be measuring antibodies throughout the trial to make sure there's no major fluctuations. Like we said, safety is our most important focus for this trial. As well as for the secondary endpoints in our exploratory type efficacy pursuit, we are looking at for patients to complete the performance of upper limb physical test. It's a routine test that's used here in DMD trials to assess kind of daily activity or daily function, as well as we're also using a standard hallmark test of the 6-minute walk test. And additionally, we'll be monitoring any kind of respiratory effects through spirometry breathing tests. To note, spirometry is both a functional test to see if there's any improvement, as well as a safety component. And then finally, we'll have both patients and appropriate patients' parents completing quality of life questionnaires. We are looking at a lot of physiological responses to the dosing of CAP-1002, but really we also want to see if there's any kind of changes in your quality of life and how you're doing in that aspect.
So just to clarify, Brian, the 6-minute walk test is for those who can walk, because in the study, non-ambulatory patients are going to be accepted into the study, correct?
Very good point, yes. 6-minute walk test will only be for those who the principal investigator deems is appropriate. Great clarification. Okay, so moving on to some additional considerations for potential participants. Capricor has contracted out with our travel agency to provide travel assistance for the patient and a single caregiver or parent. So at no cost to the participant, Capricor will cover air travel, hotel, and any kind of non-medical ground transportation. We'll also be providing reimbursements for meals, parking, a medical ground transportation, any kind of mileage if you were to drive to a clinical site, and any other reasonable expenses. We acknowledge and we appreciate the difficulty that it may have for you to travel to these clinical sites, and we certainly don't want that to be a discouraging component or aspect to joining HOPE. Additionally, we've worked with a central laboratory for them to use their regional patient centers. So rather than having to add one more thing to do during a clinic visit, clinical sites will be able to ship out blood collection kits, and they can go to their local Quest laboratory and have samples collected there. Puts a little bit more into the patient's time. They can do it locally. They don't have to travel out for it, and we'll have results ready for them as soon as they arrive to the clinical site for a HOPE visit. And one other aspect, it's not exclusionary, as Dr. Jeffries noted, for patients to be restricted to join any other clinical trial that is currently ongoing. So you've heard about the trial, and now how do you get into the trial? So we are currently working with up to 5 clinical sites that will be conducting this trial. Currently up and running, we have Cedars-Sinai Medical Center in Los Angeles. The PI there is Dr. Ron Victor, as well as we recently initiated Cincinnati Children's Hospital Medical Center, Dr. Jeffries' site there. And we are happy to announce that they have consented and screened the first patient into HOPE. They will be hopefully randomizing this patient here in the next coming weeks. So we're very excited. We're making great progress in the trial. We're also targeting University of Florida, Dr. Barry Byrne out there as a potential site, and we are also going through the contract process of working with about 2 other sites to have them up and running. Unfortunately, the link is kind of blocked here by the map, but do check our ct.gov website for an up-to-date list of activated clinical sites, and where you can reach out to them and ask for more information, talk to the principal investigator, and hopefully or maybe decide to screen and potentially enroll into the trial. If there's any other questions, contact information here is included. I do believe the slides will be distributed out to the public or to those who attended. You can contact myself. I am the clinical study manager here for the HOPE trial at Capricor, as well as feel free to contact Pat or Kath, Pat being at PPMD and Kath at Coalition Duchenne. And Pat, I'll turn it back over to you.
Yes, thank you, Brian, and thank you all for joining us. The slides, as well as the recording of the webinar, will be uploaded on the site and archived on PPMD's website. If you have questions or anything we can do to help, any questions you have that you would like answered in writing, we were happy to do that. And I really sincerely thank you for joining us. This has been really terrific. Thank you to Kath for joining us, to Linda, to John Jeffries, to Brian, as well as to Deborah. We so appreciated this webinar, and I think we've shed a lot of light on the HOPE trial, and we sincerely wish you Godspeed and success. Thank you all for joining us once again.
Thank you all.
Thank you so much.
Thank you. Thank you very much. Bye-bye.
Bye-bye.